That was fantastic. That was so much fun to listen to, and also, I'm going to be saying a lot of similar things and sort of amplifying on what Dr. Michele was sharing with us today. So, of course, I'm always challenged by technology when talking about technology. I was tasked with talking about what is currently available online for bullying prevention, and of course the answer is not a whole lot. And so then thinking about then maybe where we could go, what are some opportunities, and some examples of maybe what has worked in other fields. So I think probably the best example of what's currently online is dosomething.org. And they do a lot of outreach, but one particular example is the bully text. So you go online and you register, but it's actually much more of a sort of text messaging based intervention, and they do dating violence prevention, they do bullying prevention, they do a lot of different stuff. So you can go online and you basically sign up, and what happens is then you get all these messages, and it sort of walks you through a bullying scenario with the intention of sort of creating empathy and perspective taking, sort of what it would be like to be bullied, and how you could really identify ways to be a bystander. And then they're in the process of doing another campaign that is going to give young people some concrete examples of how to reach out to young people who are being bullied in their high schools and be a useful bystander. So, and I know that they're not necessarily evidence-based in that way, but they certainly are reaching out to researchers. They've reached out to me. I know they've reached out to Dorothy Espelage, and I'm sure others. So I think, based upon what's currently out there, this is a really great organization doing some interesting things. I did also want to mention that Dr. Dorothy Espelage and I are in the process of developing what we hope will eventually become a text messaging-based bullying prevention program, and it's still very much in its infancy, so more just sort of talking about it as opposed to saying this is what we've done, we're going to change the world. But it's currently being conceived as sort of a 6-week program. We're going to focus on the social emotional learning framework, which we've talked a lot about today. And so the idea is that young people, we're going to focus particularly on middle school students, we think, and they'll receive about 3 to 8 messages a day, and it'll sort of be topical. So maybe in the first week we'll talk about empathy and communication, and then in the next week we'll start talking about attitudes and really exploring what those mean. So we'll do 5 weeks and then a booster, and hopefully the idea is that then this will sort of sit on top of what the schools are currently doing. And we've talked a little bit about it today, actually quite a bit, the sort of the variation of programs in the schools. And so we have a general sense of sort of what all young people could use. So there's sort of these social emotional learning components that are really helpful, and we know that not all young people are getting enough exposure to all these components, so the idea would be to sort of have this lay on top and make sure that young people are getting sort of at least the minimum information that they need. So stay tuned. So what I'm going to do is instead share some examples of other work that we've done using technology and other non-bullying fields, with the potential that there might be some translation here for bullying. So one example that we've done is we developed Cyber Senga, which is an internet-based HIV prevention program for adolescents in Uganda. And the Senga is, in Uganda, sort of traditionally the aunt of the father, the paternal aunt. And her role traditionally is to talk to the young girls about what it means to be a wife, and that includes sex. And so we tried to sort of take this culturally salient figure and integrate it into our intervention. And so the idea is that there's the Cyber Senga who sort of takes you through a series of HIV information and such. And so our model was information, motivation, and behavior. It's called the IMB model. It might have application here in bullying as well. But the idea is that you have to not only have enough information about how to prevent the, HIV, you also need to have motivation to do it. So knowing that condoms are effective is one thing, but if you don't have motivation to actually use a condom, it's not that useful. And then you also need to have the behavioral skills. So if you know that you need to use a condom and you really want to use a condom but you don't know how, then that's not really useful either. So you need sort of the trilogy, you need all three, and you can begin to think about what that would mean in bullying too, right? So you sort of know how, different strategies about how to prevent bullying, but you don't really have the motivation, you don't really care to be a bystander, or maybe you have the information and the motivation, but you sort of lack efficacy, you lack sort of the behavioral skills, and so actually practicing them would be useful. So that's an example. So this study, it was 5 weeks with a booster, and it was funded by NIMH, the National Institutes of Health. What we did is, so these are the 5 lessons you can see up on the top. Information about HIV, decision-making, communication, motivations to be healthy, all of those kinds of things. And we were working with low bandwidth, and I think that even though that was in Uganda, that also has application here in the United States, that too often, particularly when we're talking about technology, we develop to sort of our own standard. We're sitting in a really cool lab, and we've got really great resources, and so we just sort of design to that and forget that there are kids in rural settings. There are kids who, don't necessarily have the same speed that we have. They might have access, but it's not at the same rate. And so we just need to be really thoughtful to be inclusive in the way that we design. And so the way that we did interactive things was much less flashy, and our designer had all these really fun ideas and then had to think about what that meant in sort of his real world and our real world here in Uganda. So this is an example of what we try to do from an interactive standpoint. So this exercise, you have a young person, and there's sort of 5 different ideas in this young person's head about, and this was focused on motivation, right? So trying to explore with young people sort of why they choose to have sex and why they don't have sex. And so in this particular example, they would click on each idea, and it would be expanded upon in the talking box. And so they're sort of physically engaging, but in a way that doesn't take a whole lot of bandwidth. So what we did is we had, it was a randomized controlled trial with about 360 young people. Half were in the intervention and half were just in called it treatment as usual control, which basically just means that they got whatever was available in the schools. And then within the intervention, half of them were randomized to the booster and half of them were not. And so what we see is kind of really interesting booster effects. So young people got the booster in between the 3-month and 6-month follow-up. And what we found was that at 6 months, those in the booster, which is the blue line, they were 80% more likely to say they had not had sex in the last 3 months compared to both the intervention, which is the red, and the control, which is the green. And then if you did have sex, our young people in the booster, only 5% reported unprotected sex compared to 24 and 21 of the intervention and the control. So we're thinking that this is promising data, sort of shows that we can move the needle, not just in terms of attitudes, but also in terms of self-reported behavior, particularly when you have a booster. So that's one example of how we might use the internet to do a web-based type of intervention. This is an example of a text messaging-based intervention. We developed a smoking cessation program, and we've tested it in Ankara, Turkey, as well as here in the United States. It also is about a 6-week program, and so this one is based on cognitive behavioral therapy. There's a lot of research out there about what helps people quit, and so what are the various components. For smoking, you have to sort of learn how, you have to get ready to stop smoking, so we have 2 weeks of pre-quit. The messages come, and you get sort of 4 to 7 messages a day, and they sort of really help you understand, become sort of contemplative and self-aware about why you're smoking, when you're smoking, and begin to think about things that you could do instead of smoking. So we sort of kind of get you ready. And then you have your quit day, which is sort of this explosion. You get 10 messages, and it's just sort of like, today's the day, right? And then that whole first week is, just sort of trying to be there with you in the moment. And so we sort of have, after this crescendo, we begin to reduce the number of messages, kind of anticipating the amount of attention that you really sort of need. You want a lot of attention in the beginning, and towards the end, you're kind of, a little bit more independent, ready to be on your own. We check in with you once a day to see how things are going, and then if you didn't have a cigarette, you get a message that's like, that's awesome, you rock. And if you said, well, I kind of slipped, then, you get a message that says, well, okay, let's get back on the wagon. So there's that interaction component, and then based upon where they are, whether or not folks are successful in quitting or struggling, then we sort of tailor the content. So we do have relapse content. So this is an example. This is from our United States program, and so these are examples across the 6-week program, but it gives you sort of a more concrete sense of what these messages would look like. And we really try to write them so that it's more of a conversation, so that it really does feel like it's a person on the other end of the line, and that hopefully it's sort of a discussion across the day as well as the week. And we also try to be really concrete, because we know from an intervention perspective that you can't just say, well, just, do better next time. Provide specific concrete skills about what that would look like. So, for example, day 15 in the middle, so it's on your quit day, and we say, I bet you're feeling cranky and annoyed right now. This is normal. So what you're going through is okay, it's normal. Take a deep breath and get through the next 5 minutes, because we know from research if you can get through 5 minutes, things are going well, because usually cravings last for about that long. So in Turkey, we had the intervention, we tested it against a brochure control. So we gave those in the control group, it was a randomized controlled trial, those in the control group, they got a brochure that provided information about how to quit, but that was all. So they didn't get any sort of daily or weekly interaction. We had about 150 folks, so 75 and 75. On the left-hand side is everybody, so almost twice as many in the intervention group, which is the red, quit versus 5% in the control group. And then when we actually looked at subpopulations, so those who are heavy smokers versus those who are light smokers, what we found is that especially among those who are light smokers, so those who smoke 20 cigarettes a day or less, that 17% of light smokers in the intervention quit versus none of the light smokers in the control. And then when we looked at males and females, we didn't see many differences between males, but when we looked at females in the intervention, 14% quit versus 0% of females in the control group. So this does suggest that, as we have been talking about today, no one intervention is going to be a universal, it's going to work for everybody. So I think it's really useful and important to understand who this might be particularly indicated for. And so in Turkey, this particular program seems to be perhaps well suited for females and light smokers. In the United States, we focused on young adults, and that's because they have the highest rates of smoking and also the lowest rates of utilizing evidence-based programs to help quit. And partly that's because there really aren't any programs for young adults to help them quit. And those that do exist are really in the university setting. So not a lot of research, and the research that has been done on university students. So what we did is we went out and we recruited about 150 folks across the United States online. They were between the ages of 18 and 24. And we randomly assigned them to our intervention versus an attention-matched control, where the control group also received text messages at exactly the same rates. We actually matched the same number of messages per day. And these messages were about fitness and sleep. So we talked about how it was important to increase your sleep and increase your fitness to help you quit smoking. So it was truly a blinded trial, which was really kind of fun. So they didn't know, they thought they were in the intervention, and we had great response rates across. So at 3 months, we had an 80% response rate among young adults, which is pretty exciting because they're kind of, they don't always retain very well. So among all young people, 40% of those in the intervention reported quit versus 30% in the control. And then when we looked at those who were not in a university setting, so in this particular group, we had a very, very diverse sample, and so we looked at young people who are minority and young people who are not in college settings, because they're the ones who are particularly underserved. So we would say that young adults generally are underserved in this area, but particularly minorities and particularly those not in a university setting. And I was pleased to see that the vulnerable group of young people who are not in a university setting, this program may be indicated for them. We had 45% of those in a university setting in the intervention quit versus 26% of those not in a university setting in the control group. So just another example of something that we're doing, we're in the process of developing and testing an HIV prevention program via text messaging. It's for 14 to 18-year-old guys here in the United States. And it's similar to our Uganda project in that it's focused on the information, motivation, behavioral program. And they get 5 weeks of messages that are really sort of focused on helping them improve their information, as well as addressing motivational issues to have sex, not have sex, use condoms, not use condoms, and then really helping them acquire the skills that they need both to sort of negotiate condom use and actually enact condom use. So we're in the process of a beta test right now, which is exciting. We're learning all the things that we need to fix before we go into field with the randomized controlled trials. So it's good. So this is also a stay tuned. Okay, so I'm almost out of time, which is good because I'm close to being done with my slides. But what I wanted to talk about also, and Dr. Michele did a great job of setting me up here, which is that young people are looking online for health information, and what we see here, these are from our national survey of LGBT and non-LGBT youth. We talked to over 5,000 young people, and that health information seeking, the red bar are those who are bullied, the youth who report being bullied. The blue bar are those who report not being bullied. So we actually have higher rates of health information seeking among bullied youth, so that suggests that it's another piece of data that suggests that they're online and maybe we should be too. At the same time, the highest rates that we're seeing are 21, 22%. So that means that there's another 80% that aren't necessarily looking for health information online. It's not that they're not online, they're just not necessarily looking for these particular topics. So I think we need to be mindful that using technology and developing these types of interventions is key, because that's where an important group of young people are. But it can't be the only thing, and so it needs to be one tool in our arsenal rather than just sort of hoping that this is all we have to do and then our work is done. So I will leave it there. Thank you so much.